Welcome to the wet clinics of the Philippine College of Physicians. Just making sure you're in the right clinic, we are going to talk about the echocardiogram. And to begin, I'd like to quote The Little Prince. What is essential is invisible to the eye. And learning how to see the seemingly invisible is an art that greatly balances the science of medicine. So as they say, let's get our hands wet and let's dive in to the what, the when, and the how of echocardiography. At the end of this session, there will definitely be something to take away for anyone interested in matters of the heart. We answer three important objectives. The first, what really is an echocardiogram and what can we possibly learn from it? When should it be done? And when is it clinically justified? And finally, how is it performed? And how can we provide answers to our clinical questions? Let's answer the first question, what? And I'd always like to begin with the end in mind. Every health encounter has a goal, which is to learn more about the patient and what ails him or her. And every echo study likewise has a goal, which is to learn more about the heart and what ails it. And to achieve this goal, we first need to provide the best possible images of the heart. An image is generated through sound wave technology. The name echocardiogram itself clearly indicates that this procedure relies on the use of basic principles of ultrasound to provide quantity and qualitative assessments of the heart by generating images transmitted by its echoes. What vital information can we get from the echocardiogram? Among the multitude of findings in a standard echo study, we can essentially obtain information about the following: fluid around the heart, as well as intracardiac masses or foreign objects, size, shape, and function of the various chambers, blood flow patterns, pressures, and physiologic disturbances, and of course, other abnormalities and anomalies such as your shunts and intracardiac defects. Let's move on and answer the question, when? Anytime we consider testing, we must ask ourselves this very important question: is it really appropriate? In the field of echo, this statement essentially summarizes the answer to this question. But let me reiterate this a little bit further. If you think about it, determination of appropriateness is a balancing act. An appropriate imaging study is one in which the expected incremental information, combined with clinical judgment, exceeds the expected negative consequence by a sufficiently wide margin for a specific indication that the procedure is generally considered acceptable care and a reasonable approach for the indication. Fortunately for us, we have international consensus guidelines to bank on, enumerating the various clinical scenarios that will benefit from cardiac imaging using your echocardiogram. However, as in any kind of medical testing, we need to exercise utmost prudence. This becomes increasingly relevant during the pandemic when we need to balance quality as well as safety. And on the matter of quality and safety, I'm happy to report that the Philippine Society of Echocardiography and the Philippine Heart Association have released local recommendations through concerted efforts of various experts and enthusiasts all over the country. And to me, this is a remarkable display of collaboration and collegiality in the face of adversity. Talking about adversity, for your patients with suspected or confirmed COVID-19 infection, The threshold for doing an echo is much higher than usual scenarios. Why? Because of the risk of infection transmission between patient and staff. The PSE recommends 6 following conditions, which all carry a high appropriate use criteria score based, of course, on international standards. Patients with unexplained shock or hemodynamic instability. Those with acute chest pain syndromes, such as myocardial infarction or pulmonary embolism. Those suffering chest trauma, such as stab wounds, blunt injuries from vehicular accidents. Patients acutely presenting with aortic aneurysm or dissection. Patients with acute heart failure. And patients with acute and hemodynamically significant valve lesions, such as severe mitral regurgitation. Note that urgent or emergent echo refers to the use of cardiac ultrasound for prompt imaging of patients with acute or unstable cardiac conditions. As such, these exams are generally performed to answer a specific clinical question and, of course, explain the acute symptomatology of your patient. In the course of our work in the medical field, we must never forget the safety of our patients and colleagues. The Philippine guideline likewise makes concrete recommendations on how we can improve the care of our patients while ensuring protection against infection and other hazards. Let's now answer the question, how? If this painting of mine depicts true anatomy, then echocardiography would be a breeze. There would be no need for any more windows. But the reality remains that there is a bony cage that makes it more challenging for us to access the human heart. In this case, we use windows through the rib cage to get better views. These are your standard windows: parasternal or beside the sternum, the apical or at the apex of the heart, subcostal or underneath the rib cage, and of course, suprasternal or above the sternum. Let's look at the images now. To acquire a long axis of the heart, which is usually the first echo image, you place your transducer the third or fourth intercostal space, direct the ridge toward the right shoulder of the patient at 9 o'clock position. This Plax view will show you the left atrium, the mitral valve and its chordal attachments to the papillary muscles, the left ventricle, the left ventricular outflow tract, aortic valve, aortic root, and sometimes a good view of the proximal right ventricular outflow tract. Now, this view is ideal for measuring the left ventricular segments, the wall motion of the anterior IV septum, basal to mid inferolateral wall. You can also get a good estimate of LA size if you compare it to the caliber of the aortic root at the level of the sinus of Valsalva here. This is also a good view to demonstrate the diastolic doming motion of patients with mitral stenosis. Now, from a Plax view, you can maintain your window while slowly rotating the transducer 90 degrees clockwise, bringing the ridge to the 12 o'clock position, then tilting superiorly. Now, you can see a cross-section of the heart, or a short axis view of the great vessels, namely the aorta and the main pulmonary artery. This view is ideal for demonstrating the 3 cusps of the aortic valve, which normally assumes what we call a reverse Mercedes-Benz sign. In this view, we need to rule out a bicuspid aortic valve, which is considered the most common congenital anomaly in adults. If you're lucky enough and the left atrium is really huge, you can actually get a glimpse of the left atrial appendage at the 1 to 2 o'clock position here. This view also shows the septal leaflet of the tricuspid valve, the right ventricular outflow tract, and the pulmonic valve. Take note of any signs of obstruction in these areas. And of course, you can see a glimpse of the main pulmonary artery and possibly its bifurcation into the right and the left branches. Now again, maintaining your current window at the parasternal region, gently tilt the transducer inferiorly until the short axis cut of the mitral valve appears. This is the best view to demonstrate the two mitral leaflets from an NFOS perspective. Patients with rheumatic mitral stenosis will classically show what we call a fish mouth appearance due to a narrowed orifice and fused commissures. From the short axis view at the mitral valve level, you tilt the transducer further inferiorly until the cross-section of the two papillary muscles of the left ventricle comes into view. This can demonstrate the contractility of the left ventricle at the mid-level. From a parasternal, we move to an apical window. The apical window can provide longitudinal slices of the heart, with the apical impulse as the reference guide for transducer positioning. Tilt the transducer anteriorly to show the more anterior structures, such as your LV outflow tract, and of course your aortic valve. This view is utilized to obtain flow across the LVOT to compute for areas of stenotic valves, and particularly in this view, the aortic. Now, from an apical 5-chamber view, we tilt posteriorly to hide the aortic valve and show only the 4 main chambers of the heart. This view shows you the inferoseptal wall as well as the anterolateral wall of the left ventricle. You can see the mitral, the tricuspid valve leaflets simultaneously, noting that the tricuspid valve leaflet is more apically inserted. It will also be helpful for you to tweak this view to allow the right ventricle to come into full view, providing the RV focus view for better interrogation of the right ventricle as far as size and function is concerned. From an apical 4-chamber view, you now rotate the transducer 60 degrees counterclockwise until only the LV and LA remain in view. Here, you can see the contractility of the anterior and the inferior left ventricular segments. From an apical 2-chamber view, you rotate once again 60 degrees counterclockwise to show the left ventricular outflow tract and the aortic valve. This aplax view can serve as an alternative to your plax view when the latter is suboptimal, and also to the apical 5-chamber view if you want to get flow across the outflow tract. Now we shift to another window, which is subcostal. The subcostal window is used when the patient is in the supine position, knees flexed to straighten the back and provide comfort, and time breath holding to optimize image acquisition. Place the transducer beneath the xiphoid process, orienting the ridge towards the patient's left shoulder. This should give you a good 4-chamber view, which becomes useful in uncovering underlying defects in your interatrial septum. Slight angulation of the probe will also uncover the long axis of the inferior vena cava, and this will provide clues to pressures on the right side as well as volume status of the patient. The final essential view is the one which provides an image of the aortic arch. Using a suprasternal window, place the transducer in the suprasternal notch while the patient's neck is hyperextended. Point the ridge towards the patient's left shoulder at 1 o'clock position until you demonstrate the long axis of the arch, its cephalic branches, as well as the cross-section of the right pulmonary artery in the center of this image. Now, not all scenarios require or allow a full or comprehensive echo study. Most especially during the pandemic, a quick and targeted study is recommended to mitigate risk of infection while of course obtaining essential information to guide clinical care. There are 4 views that can be safely and rapidly performed within a short span of time using either a portable echo machine or a handheld echo device. The plax view is used to check for wall motion abnormality and fusion, and maybe eyeball aortic and mitral valve anatomy. The parasternal short axis view sweep to glance at the great vessels and various levels of the left ventricle. The apical windows to help localize involved myocardial segments. and a subcostal view to check for IVC caliber and collapse and possible shunt anomaly. Now, final comment on optimizing the echo image. There are three that I will give to you. First, of course, is prep the patient. Position the patient properly and know your windows well. Second, know your knobs. As I say, don't be a snob with the knobs. Be attuned to the artifacts. And thirdly, probe with purpose. Always begin with the end in mind and have a pretest analysis and know what you are looking for. So to recap, I sincerely hope that you have picked up some pearls from this session on Echo Essentials. Appreciating the beauty of technology and how it facilitates echo confessions of the heart, recognizing when and when not to do testing, and of course, finally, understanding how certain basic skills can optimize imaging of the human heart. I sincerely hope that all of you will continue to do what you do best, which is to prove that there is good science that will lead to better care. Let us not stop at what we are doing, as long as there are people that can benefit from our care and compassion.